started. Today is our final seminar of the winter-spring term. So our next seminar series will start on September 5th. So if you're here, join us for that as well. And so our presenter today is Syed, who is going to be discussing the impact of collagenase on passive and active properties of muscles in children with cerebral palsy. Syed did his undergraduate degree here at the University of Calgary in biological sciences and is currently doing his Master's of Science in biomedical engineering within Dr. Herzog's laboratory. Some of the things that he is interested in beyond academia is basketball, whether it's coaching, playing, or watching. And he recently just finished watching the NBA Finals, and I was just informed that his team lost. So hopefully that disappointment doesn't carry over to our presentation today. So thanks again, Faizan, and we look forward to your talk.
Thank you very much. Can you guys hear me okay? It's fine. All right. So let's get straight into it. Yes, they almost got swept. We're not going to talk about that. So introducing the project is about cerebral palsy. Now, cerebral palsy is a group of disorders related to posture, balance, movement. It has variable clinical function or features, sorry. Now, one of those features that we see commonly is contractures, stiff muscles, altered gait patterns, and notably pain. Now, the etiology or the cause of cerebral palsy can usually be traced back to a hypoxic event where there is a brain lesion in the brain during early childhood development. Now, this figure, I just want to show is that there can be many more causes. There can be risk factors during, before, or even after birth that can also contribute to this hypoxic event. Now, let's talk about some of the classifications of CP. Now, we can classify CP based on the physical features that we see, where it can be broken down into spastic, ataxic, hypotonic, and dyskinetic. Now, among these, spastic cerebral palsy is the most common with around 80% occurrence. And the common features that you see is that weakness in the active force production or in the muscles, the altered gait, and the stiff and tight muscles. However, CP can be further classified into classification systems. The main one we will be talking about is the gross motor function, and that is shown right here. But the other ones I just want to really touch on is that there can be many, because somebody on level 4 for the gross motor function scale might be a level 1 or level 2 somewhere else. So focusing on that, we're just going to talk about the gross motor function. This basically describes the level of independent movement or assisted movement that the patient is capable of. Now, levels 1 to 3 are ambulatory, meaning they can walk with assistance or without, and levels 4 and 5 are not ambulatory. So let's talk about some of the musculoskeletal health that we see in these patients. Now, I love this figure. It basically describes everything I want to talk about. On the left, we have the typically developing children. On the right, we have cerebral palsy. Let's start from the top and let's go to the bottom. A shows you the sarcomere length, A and B, between the two different types of muscles. In cerebral palsy, we see much longer sarcomere lengths, overstretched sarcomeres, almost double. And if you know anything about the force-length relationship, you're already at a disadvantage with overstretched sarcomeres. You're losing a significant amount of force just right here. Now, let's talk about C and D. This shows you the fiber diameter. And the fiber diameter in cerebral palsy is much smaller than in typically developing children, meaning, again, you're losing force at another level. Let's talk about right here. This little image shows the satellite cell representation. In cerebral palsy, you have less satellite cells than in typically developing children, which can also explain some of the mechanical changes that we see. For example, right here, we have much smaller muscles than normal. Now, E, F, G, and H are very important because we will be talking about that a lot, but it basically shows the extracellular matrix and the intensity of it between the two types. Now, the extracellular matrix can be thought of as like a scaffolding, a support for cells. And in cerebral palsy, we see it's much more intense. very, very intense compared to typically developing children. And this will play a very large role in what we're going to talk about. So let's talk about a specific feature, mainly spasticity and stiffness. One thing I want to make clear, spasticity and stiffness are not the same property. Spasticity is related to the neurological activation of nerves. It's the abnormal processing of nerves that constantly fire, and it's a velocity-dependent resistance to stretch, whereas stiffness is an inherent property of the muscle tissue and of the material itself. It's basically the resistance to stretch. Now, spasticity, it onsets as a higher muscular tone, and it is part of the upper motor neuron syndrome that results with the brain lesion that occurs in cerebral palsy. Now, this upper motor neuron syndrome causes irregular pattern of reflexes, which sometimes constantly contract some muscles due to the injury that we see in the brain. Normally, the brain has a calming effect. It can stop you from constantly firing certain muscles while firing the ones that we voluntarily want to fire. So one thing I really want to talk about is this upper motor neuron lesion. Now, it has two types of features. Positive, meaning it adds something, and negative, which means it takes away something. So the negative feature of this upper motor neuron syndrome is the muscle weakness. Kids with cerebral palsy are much weaker. The positive features that it adds something can be split into the dynamic and the static. Now, while the dynamic is very important because it leads to impaired function, today we're just going to talk about the static, mainly the spasticity and the hypertonia and the reduced range of motion it leads to. Now, I keep mentioning stiffness. So what is stiffness? Stiffness, or the resistance to stretch, can be explained by the simple spring. The spring stretching with a certain force goes a certain distance. But what if I drop that spring in like a bucket of glue or something, and it started having these bonds that connect to each other? Now, that same spring would only stretch to a fraction of that distance, despite it being the same spring, but now it has a higher stiffness. Now, my question is, we see these stiff muscles in cerebral palsy a lot. So what if I wanted to go back to the original spring? What could I do right here? Now, one idea is you could start making cuts in these inner connections, releasing some of that stiffness, and normally then you would be able to go back to the original spring, going the same distance. Now, I want you to hold on to that idea because it'll be very important later, but what I really want to talk about is this increased stiffness in cerebral palsy muscle. Now, there's two main factors that it is due to. The first one being increased extracellular matrix volume, meaning that entire matrix is just intense. There's more connections, there's a more intense network. And in our ECM, the majority of it is made of collagen. There's different collagen types. The main one is made of networks that resist that stretch. Now, the second reason that we have increased stiffness, now this is going to be a trust exercise, so you're going to have to bear with me, is long sarcomere lengths. Now, to explain this, we first have to learn about titin. Titin is a spring-like protein which at long lengths gets engaged and it produces a certain level of passive force. But what if I told you that kids with cerebral palsy have a lower amount of titin, but a higher amount of passive force in this level, in the sarcomere level? Now you'd be like, wait, that doesn't make any sense, right? Hold on one second. Now, this is a graph showing myofibril data. The sarcomere length is a function of the stress. As it stretched more, you would expect a higher passive force in these myofibrils. And it is true. Since typically developing children have more titin, they produce more passive force at the same sarcomere length. Now, the difference is the in vivo sarcomere length we find these muscles at is not the same. So let's say we took 4.0 at the same sarcomere length, the typically developing children in the green dots and the green line have a much higher passive force than in the black line, which is the CP myofibrils. Now, unfortunately, these muscles are not found at the same sarcomere length in vivo. CP is usually found at around 3.7, and typically developing is around 2.6. Now you can kind of see why we have that higher passive force, because even though the typically developing have more titin, they're just at a lower sarcomere length naturally, so they produce less passive force than cerebral palsy and sarcomeres. Now, after talking about stiffness, I want to talk about some treatments, but this is mainly for spasticity. The treatments that the next 3 treatments I'll be talking about are all for spasticity. And the first one I want to talk about is SDR, or selective dorsal rhizotomy. Got it around the first time. Okay. So SDR relieves hypertonia, that higher tone or those stiff muscles, by identifying problematic sensory rootlets or nerves that are continuously firing, that are causing these contractions. And it basically cuts them. Now, this is a surgical technique. There are inherent risks with surgery, and it is slightly more accessible than some other treatments. However, there are specific conditions that have to be met. This type of treatment does not work for every patient, especially if you have a weaker lower limb or trunk, because what this treatment does is it removes some of that hypertonia, and that stiffness unmasks the lower limb weakness. CP muscles are weaker, so if you remove that weakness, or if you remove that stiffness, if you could normally walk with a higher level of stiffness and the hypertonia is gone, now you have to walk with just your muscles, which are, if they're already weak, you will not be able to walk anymore. Moving on to the second surgical technique, despite it being a hard name, it is the intrathecal baclofen pump. It's basically a pump that is implanted close to the spinal cord, and it releases a small amount of baclofen. Baclofen is a muscle relaxant, and it delivers it straightly to the spinal cord, and it relaxes muscles, removing some of that spasticity. Now, again, being a surgical technique, there are risks, and also there's a risk of infection, especially because you're implanting a foreign object into your body. But the other thing I want to talk about is the risk of overdose. Now, this is very important. Baclofen is a muscle relaxant. As you start increasing the dosage, you start running into very important consequences, because you can get respiratory depression, and at high doses, it can lead to coma. So there are positives to these treatments and also negative. Now, probably the most well-known one is botulinum neurotoxin A, or Botox. Now, Botox inhibits the release of acetylcholine. It basically stops cells from firing postsynaptically, and it basically chemically denervates the muscle. This is the very important part. There's so much conflicting data. There's a lot of data supporting the fact that Botox can reduce spasticity and relieve some of that range of motion. However, there are also some articles that show that muscle weakness, fat infiltration, and fibrosis can occur even in muscles that are not related to the ones that are injected. Now, some of the good points are that it's less invasive than surgery. It is repeated injections. However, it is temporary, because once you chemically denervate, it starts building more nerve outlets that will return to function eventually. But let's talk about this last point, some of that muscle weakness and neighboring weakness. This was a tissue injected with Botox 6 months after compared to the control. You can see a lot of fat infiltration and fibrosis, and in the contralateral, so even in a neighboring muscle, you also see fat infiltration and fibrosis, meaning when we use this Botox in a clinical setting, we did not know all the effects right away. And a lot of clinicians will argue that Botox is really good because it restores some of that range of movement, but there's also downsides such as the muscle weakness. So it's basically a balance of the two. But what if there was an alternative? Now, I don't know why I animated this, because I already spoiled it in the title slide, but collagenase. Collagenase does not work on spasticity. It works on stiffness. And that will be explained because it breaks down the peptide bonds in the collagen. And it's substrate specific, meaning the type of collagenase that you use will determine the action that it has, which is really good because collagen is probably the most common protein in our body, around 25 to 35%, meaning it's also present in a lot of our vital systems, such as the cardiac system. Now, one thing that is very important to talk about is the diffusion through the muscle belly. Now, collagenase is usually injected into areas of fibrotic tissue and buildups. It's not injected into muscles. So if we're looking at collagenase to work on a muscle, it might diffuse, get into the bloodstream, and we don't know where it could go after that. But we kind of hold on to that for now because it's actually been used before. Collagenase is usually used after injury because there's a lot of fibrotic tissue that occurs, especially due to burns, and it's used in that wound management. It's also been used in fibrotic disease states like Dupuytren's and Peyronie's. This figure just shows an example of Dupuytren's where you have this fibrotic cord of tissue. It's it's a very intense amount of tissue that is injected with the collagenase, either directly into the tissue or outside, and it either breaks it from outside in or inside out. And it actually showed that there was a removal of contracture after the collagenase injections. This is very promising because this also leads to the purpose and hypothesis of the study. So what do we do? First, the aim was to establish a baseline, because without a baseline, you can't really tell if an intervention works. So we have to figure out the passive active force and sarcomeric protein content in these CP muscles, so then we can try our intervention. It was hypothesized that the CP muscles will show a decreased passive and active force because it has also been showed before, and that specific sarcomeric proteins will also be decreased. This was shown once before, but not all the proteins were tested. Now, the aim two is the actual fun stuff, is that investigating what collagenase does as an intervention. Right now, it's just on the passive force and the total protein content. Now, due to how specific collagenase is as an enzyme, it was hypothesized that the collagenase will decrease the passive force, but it will not impact the total protein content because it will only act on the substrate. So how do we do aim one? Let's talk about some methods. Now here, what you see is a force transducer and a length controller. They're basically two hooks, and we got bundles of CP tissue, and we basically just stretched them. That's a simple way. It was basically trying to figure out the Young's modulus by doing a stress strain curve and taking the slope of the linear region. Now, the active force is a little bit more intense because you have to skin the muscle, get single fibers, and chemically activate it using ATP and calcium. As for another method we did, gel electrophoresis for the protein content, which just separates the proteins based on size. And this was used to determine myosin, nebulin, actin, and titin. So what did we find? Well, what we found was we first tested the Young's modulus of these samples, and we found that it was significantly different between the two different gross motor function groups. Now, 1, 2, 3 being ambulatory, 4 to 5 being non-ambulatory. And this result makes sense because with the Young's modulus on the Y and the group on the X, and it being significantly different, it agrees with what we've talked about before, because as you lose mobility, you stop using muscles, leading to atrophy, more fibrosis, and more collagen buildup, and thus more passive force and more stiffness. Now, moving on to the second result, it was that the active force in healthy adults, yes, healthy adults, not typically developing, is higher than in cerebral palsy single fibers, skin single fibers. And this was almost a 46% decrease in the active force production between the two groups. It's a very significant loss. Now, one more baseline, the protein content. Now, when we talk about protein content, there was gel electrophoresis, and the myosin is pointing right here. This is myosin all the way across. Between healthy adults and cerebral palsy muscles, there was no significant change in the myosin. On the y-axis, you can just see the ratio of the cerebral palsy to a healthy adult, with 1 being the baseline and the cerebral palsy being some variability, but being similar. Now, actin was significantly decreased. actin is right here at the bottom of the gel. It was significantly decreased between the two groups. And it was about 35% lower than in the healthy adults. As for one of the other ones, titin. It will be a little hard to see at the back. I'm sorry about that. But there's a band right here at the top that shows you the titin content in these gels. This was also significantly decreased, about 30 to 35% in the cerebral palsy group compared to the healthy adult. Now, so we've established a baseline, but what did other literature say about these results? Now, normally we would get like a one-to-one comparison, but unfortunately there hasn't been much work on the molecular level in terms of CP. There's a Rick Lieber group which did agree with the lack of active force. They agree that there is decreased active force mainly because of the overstretched sarcomeres and the diminished proteins that were decreasing the active force too. Now, the Young's model is increasing with gross motor function level. This was also agreed upon by some papers that show that there's decreased soft lean mass as you go higher in this gross motor function levels. So level 1 would have a higher soft lean mass than level 4. Thus, you can conclude that they have more movement, less atrophy, and less fibrosis. Now, moving on to the intervention, the fun stuff, testing collagenase. Now, this is investigating the impact of collagenase on the passive force and the protein content. So how do we do that? Well, it is a very similar setup. It is a better picture, force transducer and length controller with a sample in the middle. And basically, the bundle was hooked up between the two. Again, it was mechanically tested by stretching and then incubated in collagenase and then tested once again. And this just shows a force trace of how it would look and the two outcome measures that we took from the graphs. On the blue, you see before collagenase, and at the top, you see the peak force, steady state when it's levels out. And you can already kind of see a spoiler of the result. There is a decrease in the passive force. Now, another method we used was red picrocyrus staining for the collagen content. Basically, the samples were cut with a microtome and then stained using red picrocyrus staining, and then analyzed using image J, and we got the total collagen content. And this is a BCA assay where basically you solubilize the sample and test for the total protein content. Now, what do we find? This is what we found. This is the peak stress after collagenase incubation, which makes sense. And it was significant at every single strain and across all the samples. There was about a 50% decrease across all the strains on average, depending on the dose of collagenase used. This is also true for the steady state stress. The stress on the y-axis and strain on the x, we saw the same pattern, significant decrease across all strains after collagenase incubation. And good news, the total protein content did not change significantly after collagenase incubation, which is what we were hoping to see. On the y-axis right here, you have the total protein content and across all the samples we incubated in. Now, what do these results mean? Now, I'm not going to reach out and say, yes, this can cure the stiffness we see in CP. But for now, what we can say is that the collagenase was successfully able to decrease that passive force and the Young's modulus, both around 50%, depending on the amount of collagenase used, without significantly altering the total protein content. This is very important because if we started seeing is degrading proteins, it's questionable as a treatment because now your active force is compromised while your passive force is fixed. Let's talk about some future directions. I've already done some testing where I incubated a fiber in collagenase and tested to see if it will produce active force. Fortunately, it did, so it does not ruin the active force. But unfortunately, it was not at the temperatures that would be optimal for collagenase incubation. There was one bundle we incubated at 37 degrees and tested it, and it did produce force, but the other ones were tested at room temperature. So this single fiber testing, we have to do again at a probably body temperature to see if collagenase will impact active force or not. And there's also gel electrophoresis. So the same thing, again, myosin, titin, nebulin, actin. We want to see if they get degraded. Those same gels, if you see their position change after collagenase incubation, you know there's something going wrong right there. And another future direction is the animal model. Now, this is a little bit difficult. There is no direct animal model for CP just yet. It is due to the reason that there's brain and motor development differences among animals. So like rats might not be able to be used as a direct comparison. However, there is good news because there was a fetal hypoxic group in rabbits, and they showed that the offspring had an increased tone or stiffer muscles after that hypoxic event occurred while the offspring was still with the mother. And it did show some significance. This could be a good route to go down, but this also kind of stops how far collagenase can go, because before testing it, in humans or clinically, you have to go to an animal model. But if there's no animal model, you have to create one, which can also be difficult. Now, in my opinion, this is the most important slide. We have been trying to do a baseline for the actin length because, as I mentioned, the actin was significantly decreased, but there was also another protein called nebulin. And nebulin in this image right here follows the actin, and it's basically called the actin ruler. It was also significantly decreased. What we want to know is whether these filaments of actin are just gone or are they shorter on average. So what we decided to do was use tropomodulin labeling. So tropomodulin is this end protein, and it will label here, and we would go to the next tropomodulin and just divide it by 2, remove the width of the Z line, and see our actin lengths. Unfortunately, our antibody is getting stuck somewhere around this area. It's only labeling here, which makes no sense. There is no tropomodulin there. So what is it labeling? And it's specific labeling because there's specific patterns all across the different sarcomeres. And the length is too small for this to be actin. So if anybody knows anything about antibody labeling and why it could be getting stuck here, it'd be very helpful. Also because the antibodies are very expensive, but we're not going to talk about that. And after figuring this out, we'd be able to complete our baseline and then focus on our collagenase studies, especially in terms of active force. Because once we incubate all those single fibers in collagenase and complete that testing, then we have to think about how it diffuses through the animal model. Now, to do that, you would have to dye the collagenase with some sort of dye, inject it into an animal, and see how it diffuses through the muscle belly. And I believe for now, that is it.
Floor is open for questions. Who would like to get us started?
Or if you know anything about the antibodies, please.
I'll start off. Do you have any idea like how long this collagenase effect would last? Like Botox?
Yeah. Unfortunately, when the Dupuytren's went for a follow-up, it was shown that there is fibrosis that occurs again. I believe is a 6-month follow-up, but you could just use collagenase again. But unlike Botox that has to be injected, it is not, for now, it's not having that same muscle weakness effect. So that is good news, but it is not a permanent solution for the stiffness.
How quickly does it work with the collagenase? Like, how long does it have to be exposed to it that it changes these properties?
It's a very good question. So the bundles were incubated for 2 hours at 37 degrees. I'm not sure how it would work in humans because of all of the movement, but that would have to be tested based on the dosage.
I have another question for you.
Yeah.
What comes first, the spasticity or the stiffness?
It's a very good question. I believe there are 2 different properties because as soon as you have the brain lesion and that abnormal firing of reflexes, you start seeing that spasticity. Whereas the stiffness, I believe, is just, it can be due to the lack of movement that comes along with that spasticity. So it might be that it comes after, but I'm not too sure about.
So I guess as a follow-up question, like you give this as a therapy to someone, you reduce their stiffness, but they still have this spasticity.
True.
But then not just exacerbate, like we'll just go back to this super stiff position and like
Yes.
still in this hyper.
Yeah, that's a big question. They would go to that same position again, but that's where you have a combination of treatments. So you can use dorsal rhizotomy or the baclofen in combination with the collagenase, because that would take care of your stiffness, and the other treatments would reduce the spasticity. The main point is we want to restore the quality of life and, more importantly, the range of movement, because one problem that clinicians see is that therapy has like physical therapy is really good for reducing some of the symptoms seen with cerebral palsy, but you cannot really commit to the physical therapy all the time just due to the limited range of motion. They cannot do the exercises completely and to the full effectiveness. So using collagenase and another spastic reducing chemical would restore some of that range of motion and might help that physical therapy be better in overall without the harmful effects.
I think I might have missed it. What type of muscle did you use?
What type of muscle?
Like was it Dr. Lawler's?
Yes, it depends on which aim you're talking about, because for aim 1, we use semitendinosus and adductor longus. For aim 2, collagenase, it was all adductor longus for now.
So do you expect the protein content to differ between the, like if it's a completely different type of muscle, like the soleus or DL? Do you expect the same thing?
It might differ, but since we're comparing it to a control that's from the same muscle, that would be just determining between those two muscles. So like a VL control and a VL CP, it would only identify changes in the CP. If that makes sense. There might be a change between soleus and VL, but it wouldn't matter when you just compare between the two groups.
Is there any data published on like the mechanical properties of muscles from typically developed children, and does it closely align with your adult group, or what are some of those differences if they exist?
I've seen one article only on the molecular scale, which was also published by our group with Tim. But normally there's not too much data on the molecular level, especially for typically developing, because there'd be no reason unless you were trying to find a control for your CP. So it might be helpful to do it with typically developing, but those samples are also hard to get.
The dosage of collagenase that you use, was it similar to those fibrotic diseases like Peyronie's or?
The dosage is different because in Dupuytren's, you have a fibrotic cord, so it's a buildup, and you can easily target that area. However, in a bundle, it just sits in the solution, if that makes sense. So you have to use a different concentration. Ours was done through trial and error. It was a dose-dependent response. The higher concentration collagenase you use, the higher the passive force decrease by. If that makes sense.
So what's the right amount?
There is no like correct amount that you could give universally, but if you're talking about the ones we used in our, it was in the 100, they're arbitrary units, but it was in the 100 AU per.
So how would you determine what dose to give like a child?
That's a very good question. That's also a very difficult question, because in all these CP cases, you won't find a one-to-one. All of them are different. All of their physiological makeups, the amount of collagen they have, their ECM, everything different. So you're based on the clinician's opinion, and you would have to start at a very low dose, because again, if you see that diffuse through, it could have other catastrophic consequences that we don't want to see.
Yes.
So you said at some point that the stiffness, the increased stiffness is because of an increase in the volume of the explanatory application. So do you know if there is a change also in the type of collagen?
Oh, that's a very good question. I don't believe I saw if there was a specific change, but
Quantitatively, it's higher.
Quantitatively,
but
qualitatively.
hospital, like,
Yes.
stronger network or?
Yeah, the paper didn't mention anything about it being stiffer because I was looking for that too to see if there was a different collagen. I believe it's just more intense. Just like if you have an injury, you start seeing fibrosis and that buildup just a more intense ECM other than the same volume, but like a stronger type of collagen.
And so collagenase is directed towards a specific type of collagen or?
Yes, it mainly targets, I believe it's collagen type 1 and 4, but I'll have to double check because there's different types of collagenase. There are some commercial available collagenases that have been FDA approved, but that's like a commercial type and it's a specific type of collagenase. So we're also gonna have to investigate what type of collagenase would work the best.
Oh,
I have some general questions about what is a satellite cell?
Satellite cell, yes, it's a very good question.
What has to change within that satellite cell? Like if I understood correctly, you said that something about the cell also that changes this stiffness properties.
It's just,
Or maybe I misunderstood.
no, you're right. So basically, the satellite cell is a precursor to, some people believe it's what you need to build a muscle or form it properly. And when you see it being decreased in the cerebral palsy muscles, it could explain some of the properties, like why you have such small muscle volumes. Not necessarily the stiffness. The stiffness is, I don't believe is related to the satellite cells. But yeah.
And then within CP, are some muscles more affected than others?
Yes. It's a very good question. We don't know why, but when you see the brain lesion and cerebral palsy and the clinical features, it's always some of the same muscles that are always affected by spasticity. The flexors, like there's different types of flexors, adductors, extensors, and for some reason it's always the same pattern. Now, is it because we don't know if it's because the brain lesion occurs in the same part of the brain or the development just works in that time period, that specific chronological order, but it is always a specific pattern for the flexors.
to add on to that, is this kind of issue where, like, you know, in World War II, all these planes would come back with all these holes, and then
Yeah.
like, the same kind of thing. Like,
Yeah.
if you get a brain lesion anywhere else in the brain, you're
Yeah.
dead.
Yeah.
Like, so is this just self-selecting?
Yeah,
survival?
it could be. It could be that it's happening in that specific region that always leads to cerebral palsy. But if it happened in another region,
Yeah, like
Yeah.
centimeters off. and
Yeah.
It's like, oh, your lungs
just don't,
can't work to die.
yeah. Or there could be some pattern we don't know just yet.
But we really don't know.
Yeah.
Final, Walter?
You showed some results that the elastic modulus was greater for gross motor function 4 and 5 compared to 1 to 3.
Yeah.
Did you also check the amount of fibrosis in those two groups, and did it parallel the amount of collagen?
The only thing I can speak to that is when we were given those samples from Dr. Howard, they also did collagen content testing. I'm not sure the exact protocol that they did, but when I did run some like comparisons, and I'm not sure if it was significant or not because we didn't have enough samples at the time, but I can run that again and see the amount of collagen. I don't know about the fibrosis content because that has not been tested just yet.
But I assume you have a number, you have a collagen content for each of your samples.
Yes.
So if you plotted that collagen content versus the Young's modulus that you measured, would you then expect to see like the relationship there, you know, more collagen, greater elastic modulus in the passive case?
Yes, when I did run that with the numbers that Dr. Howard gave me, it was significant and I followed that correlation, but I didn't use that because I'm not sure the protocol they used for their collagen testing. And we don't have the numbers for the semitendinosus collagen content, which is what the Young's modulus results are based on. So you'd have to measure the collagen content in the semitendinosus, and then I could answer that question directly.
And also, you know, I mean, they send us this teeny tiny couple of millimeter piece tissue, and the muscle is like this long.
Yeah.
So do you know anything about variation of fibrosis in a muscle, or when you get a small sample, do you think that's fairly representative of the whole muscle?
I can speak directly on that because one of our results, we were measuring collagen content and we were trying to correlate it to the decrease in Young's modulus. And for some of the results, sometimes we got an increase in collagen, but a decrease in Young's modulus, which makes no sense. What I think happened there was when you have a biopsy and you take a fascicle, we tried taking the fascicles as close as possible, but there might have been a difference in the amount of collagen, just how near they were from each other, which meant that the fascicle that was incubated in collagenase and without collagenase was significantly different already in the collagen content. So we tried to control that, but it's very difficult. So yes, to answer your question, there was differential fibrosis just in those tiny samples.
And you mentioned that the rabbit model that seemed to have stiffer muscles. In the rabbit model, are stiff muscles also associated with an increase in collagen or extracellular matrix fibrosis?
I'm not sure they measured those. They were just measuring the muscle function because it was more of not a pilot, but it wasn't done before. So they were just trying to figure out if it actually produces the same features that we see in CP. But I can check again if we get a working animal model.
Do you remember at all how they measured stiffness?
I don't believe so. They're just measuring. Yeah, so.
The other thing, you give the passive forces there as a function of strain. Can you remind me again what zero strain is?
So zero strain is basically the bundle between the hooks, and when it starts producing about 0.1 millinewtons of force, and when it was visually taut. So that's its baseline. Then any strains upon that were based on how the length of that initial baseline. So like 1% would be based on the length of that initial baseline bundle.
And you know if that length, that zero strain length changes from before to after collagenase exposure?
I don't believe so. Because when it's incubated, it should be the same. I don't believe it changed much.
I mean, do you take afterwards, did you take the same lengths as zero that you had before? Or did you retest it where you found your 0.1?
Yes, it was baselined again.
You based it on force.
And the visual tautness, yes.
But you don't know if it's exactly the same lengths. Sure.
So it's the collagenase study. I believe we did not be measured. It was.
Oh, it was just
again, it's not the ST, the beyond the small.
Yes, it's not the ST.
Yeah, it's the collagenase one. So I believe we did not measure it again. So just you incubate the collagenase, and then you leave the muscle as is or the bundle as is, and you start to stretch it from this.
So therefore, the zero length would be the same.
It's the same, yeah. The same.
Yeah. And just a comment to the satellite cells, because we were talking about that a little bit yesterday, because the published data seems to suggest that satellite cells are less spastic muscles, and that's all Rick Weaver's group many times. And I think we discussed a bit that Patrick Luber actually found that that's not correct, but I'm not sure if that's published. I don't think I've seen that published. But last year at the muscle conference, he said that they found the same number of satellite cells in the spastic muscles compared to control muscles from children that they had. So they had actually children control. So I think there's a bit of a debate at the moment whether or not satellite cells are really reduced in spastic muscles of children with CP. But that's what you're showing is what's published.
Yeah, published data.
Just, you hinted about the active force properties in your future directions. Do you hypothesize that collagenase won't affect active force at all? Because the total protein content is maintained, or?
Yes, and it's also been shown that collagenase is very specific. It just acts on the substrate that it's focused on, but that's why you have to test it. I'm expecting no change in the active force, but unfortunately, why the testing is not currently working is because muscles at 37 degrees, they don't like that. Because if you incubate at 37 degrees, the whole muscle doesn't like it. It gets shredded a little bit, it changes a little bit, and the active force goes down just due to the heat, not even due to the collagenase.
So let's say you think it won't change at all.
Mhm.
Why would it increase? Because like if it decreases stiffness, there's more range of motion.
Mhm.
Wouldn't you get more active force then?
That's a hard answer to say because we all have these pre-existing conditions. It's not just the stiffness. You have the neurological effect, and also if the satellite thing is right, you have also that. But it would help build some muscle because it would restore some of that range of movement, if that makes sense. Yeah. So just for physical therapy, it would be better. Just say that.
Okay, do we have any final questions for that?
Any antibody stuff, please? Or if anybody has any healthy adult tissue just laying around, maybe in your legs too, please let me know. We've run out and we need it as a comparison. So.
As I can see, Martin McInnes who takes a little biopsy.
True.
All right, well, let's thank them again. This year's seminar series, see Jackie and Steph next fall, September 5th. Remember, first one, so please be here and enjoy the summer break.
Thank you, children.
Okay.